the two big aspects, unrealistic view of cure with catheter ablation and the unrealistic waiting time. Andrew Ha was recruited to the Peter Munk program to give you a realistic view of outcomes and a very reasonable time, and that's what he is telling you about. It's my pleasure to introduce the next speaker, Dr. McDonald. He's not only trained in cardiology, heart failure, and transplant, he's also trained in the ways of the Jedi. What I mean by that is he is also an electrician. We are glad to adopt him as one of ours, and he is going to tell you everything you need about heart failure and the device interaction. And truly, he's one of the unique physicians, I think, in Canada who is fully trained in both aspects.
Thanks very much. I'm just delighted that the electrophysiologists let me hang out with them. So over the next 20 to 25 minutes, we're going to demystify, I hope, some of the nomenclature and the indications for appropriate referral for invasive device therapy for heart failure, specifically implantable defibrillators and resynchronization pacemakers. I have no conflicts of interest. Again, first objective is to address the why, so to understand the rationale for device implant in the heart failure population, focusing on the benefits of a defibrillator and an AICD, and the benefits of resynchronization therapy, CRT, and what specifically would I need to know as an audience member, and focusing on the current indications, the guideline recommendations for referral for these devices, and some of the limitations, because I think that's an important part of the message. For those of you who have seen me give heart failure talks in particular, I tend to show a slide like this, which really speaks to the last decade of heart failure management and the role that pharmacologic therapy has played, or I should say not played. Really, if we look at the positive trials in the last 10 years, we've seen some benefit with the angiotensin receptor blockers, some benefit with aldosterone antagonism. Emphasis trial was a victory for medical therapy a year ago, or 2 years ago now, when it was published in the New England Journal, looking at eplerenone in mildly symptomatic heart failure. But the list of negative or neutral trials or disappointments for pharmacologic therapy, this is just a sampling, and it's really quite extensive. Any way you try and attack the pathophysiology of heart failure with the different categories of drug have yielded more disappointments in general. So that really begs the question, are we seeing the limits of medical therapy? And certainly in the last 10 years and into the next decade, we're in the machine era. And by machines, I mean implantable defibrillators to improve survival, cardiac resynchronization therapy to improve survival, and for a minority of patients, ventricular assist device as long-term therapy or bridge to a definitive therapy, which right now is heart transplantation. I think just to define some of the terms to put everybody on the same page, a pacemaker really refers to leads or wires, we call them leads, in the right ventricle or the right atrium attached to a pulse generator, which is the pacemaker battery. And the indication for a pacemaker is just to prevent bradycardia, consequences of bradycardia. So these really are devices that work when the heart is too slow and they pace at slow heart rates. A defibrillator has all the functionality of a pacemaker. In addition, it has the ability to deliver a high-energy shock in the event of a tachycardia that could be life-threatening, specifically ventricular tachycardia or ventricular fibrillation. And cardiac resynchronization therapy is a heart failure-specific therapy. It's a pacemaker system, has all the functionalities of any pacemaker, and it's often combined with a defibrillator in the same device, but it doesn't necessarily have to be. If it's combined with a defibrillator, we call that CRT-D for defibrillator, or on its own CRT-P for pacemaker, and this really offsets the adverse effects of dysynchrony in the heart failure patients, and we'll talk about what that is and where we are at with that. And ideally, unlike a conventional pacemaker, a heart failure resynchronization therapy pacemaker is designed to work 100% of the time. You want the heart to pace every beat. Just focusing first on the implantable defibrillator story, this is really to prevent sudden death. And sudden cardiac death usually results from ventricular fibrillation, which is preceded by ventricular tachycardia. and the overall, understandably, overall prognosis is very poor, particularly if you have a cardiac arrest outside of the hospital. Fewer than 10% of people would be expected to survive, and much has been made about the chain of survival, and this is all geared at delivering high-energy defibrillation to patients who've had an out-of-hospital arrest. They still say it's a manifestation of cardiac disease for the first time in 50% of patients. And most talks on the epidemiology of sudden death have a slide like this, and I think it's instructive. Certainly, most people who have out-of-hospital cardiac arrests represent the general population at risk, but within the general population at risk, there are higher risk subgroups. And if you look at the left side of the graph, patients that have the highest incidence of sudden death or out-of-hospital death are patients who have structural heart disease, low ejection fraction, presumably with a lot of scar burden in their heart, people who've already arrested once, so if you've died once, you're more likely to die again, and patients that are very high risk post-myocardial infarct, people with a lot of aneurysm or scar and a lot of arrhythmia after their infarct. And I think in 2012, the science has really put us on the map here. These are the patients that are now eligible and should be thought of for referral for device therapy. These people are at the highest risk of having a sudden cardiac death and may benefit from a defibrillator system. If we look at the natural history of heart failure, you may be familiar with the American Heart Association categorization of heart failure. It's really a disease continuum where you start out with stage A disease. That is to say, someone has risk factors but no manifest structural heart disease. Stage B disease is somebody who's got structural heart disease, your hypertensive heart disease, post-myocardial infarction. Half of the patients post-myocardial infarction over time will develop a heart failure syndrome. That means about 1 in 5 of us in the room, and once you reach symptomatic heart failure, your prognosis really takes a turn from the worst. By the time you're hospitalized for the first time with heart failure, your prognosis changes, the game changes, and you tend to be on an inexorable decline towards end stage or stage D heart failure. And the death is really related to progressive heart failure death, death by drowning, or sudden cardiac death, death by dropping. And a defibrillator aims to prevent sudden cardiac death. There were a series of trials way back in the 1990s that looked at the highest risk post-infarct patient population and recognized and were able to demonstrate that if you had ventricular tachycardia that couldn't be suppressed with antiarrhythmic drugs in a controlled EP testing environment, that you would be better off with the defibrillator. Advancing the thinking a little bit in studies like the MADIT-2 study, which is probably the seminal paper that really just took patients with post-myocardial infarct with a badly damaged ventricle and said everybody with a low ejection fraction post-myocardial infarct gets a defibrillator or they don't in a randomized control setting. And this study found a 30% reduction in mortality with defibrillator compared to no defibrillator therapy. And this is probably the simplest. It's relatively crude, but it's a simple and effective way to risk stratify patients. If you have a huge burden of scar and have a damaged ventricle and your ejection fraction is less than 30%, you are at sufficiently high risk of sudden death to warrant consideration for a defibrillator. On the heels of that MADIT-2 study was the Scud Hef Trial in the early 2000s. And this looked at a broader spectrum of patients, not just patients who'd had a heart attack, but patients with dilated cardiomyopathy, non-ischemic cardiomyopathy, and said those patients with an ejection fraction less than 30% would either receive a defibrillator or placebo or amiodarone. And the expectation is that a defibrillator might confer a survival advantage, amiodarone might confer a survival advantage. And the key learning from this study was that, number one, the broad spectrum of heart failure patients with a low ejection fraction benefit with a defibrillator, benefit from a defibrillator. There was about a 25% risk reduction in mortality. And the other key finding was that amiodarone is no better than a placebo in reducing sudden death if you're not protected by a defibrillator. So now twin studies that really shaped the Canadian Cardiovascular Society recommendations, and the recommendations currently stand, haven't changed for a few years, that primary prevention in automated implantable cardioverter defibrillators for heart failure patients should be considered if you have a low ejection fraction, an EF less than 30%, for at least 1 month following a myocardial infarct to allow assessment of the final effects of the myocardial infarct. And in the case of dilated cardiomyopathy, you want to wait at least 3 to 9 months to make sure that the therapies have been optimized. And these patients should be considered for defibrillator. Not everybody is appropriate, and not everybody will want one, but a discussion should probably, and a referral should probably be considered. And one important caveat that's often overlooked is that patients who are candidates for defibrillators should otherwise have a very good life expectancy, a reasonable life expectancy with reasonable quality of life for about a year. And that's why patients with stage 4 or class 4 heart failure or stage D disease are not traditionally candidates for a defibrillator. So that's why it works. That's the rationale. Of course, in real life, every decision has to be weighed by the downside, much the way Dr. Ha outlined the risks and the benefits for an individual patient with atrial fibrillation ablation therapies. It's the same kind of conversation that a person has to have with a patient referred for a defibrillator. Certainly, we know that we can reduce the risk of sudden death and improve survival on a population level, but patient preference and patient understanding of what they're signing up for really needs to be taken into consideration. There's a variable absolute risk of sudden death within patients, and there are a number of other ways to risk stratify patients. As I mentioned, ejection fraction is just one way to do it, and it's relatively crude. You have to weigh the peri-procedural risks. There's a 1 or 2% chance of an infection, which can be catastrophic, and those of us who implant devices lose a lot of sleep over this. The leads can dislodge, pneumothorax, pericardial tamponade, device malfunction. Inappropriate shocks is a huge topic of conversation with patients and can be the difference maker for some patients, and ultimately patient preference weighs heavily into the final decision. I haven't put in this box the other issue of device recall. That's a whole other can of worms, but it certainly enters into the psychology of patients and their providers. So switching gear from the defibrillator, prophylactic defibrillator for heart failure patients, to a therapy that not only improves survival but also improves symptom status is cardiac resynchronization therapy. And resynchronization therapy is a therapy to overcome dysynchrony. And historically, what we mean by dysynchrony is electrical dysynchrony. Patients with a broad QRS on their surface ECG, typically a left bundle branch block, these patients have depolarization and activation of their intraventricular septum and the right ventricle milliseconds before activation of the left lateral wall, and those milliseconds count. It results in net inefficiencies in myocardial contraction as the work of depolarization and contraction is wasted deforming the contralateral wall when it could be used to overcome afterload and eject blood with each systole. Typically, patients with a left bundle branch block, when you do advanced imaging techniques like dysynchrony echocardiography, for example, you can demonstrate that the lateral wall and the septum are reaching their peak velocities at different times. That's one index of mechanical dysynchrony, no matter how you measure it. Patients with a broader QRS, so a QRS duration of over 150 milliseconds in particular, almost always have some measure of dysynchrony. Some patients with a narrower QRS also have mechanical dysynchrony that you can measure on imaging, but not necessarily. And this is an area of intense research. And we make a big deal about left bundle branch block and heart failure because it's common. About 30 or 50% of the patients with low ejection fraction will have a left bundle branch block, compared to about 1% of the general population. And it's a marker of increased risk and has pathophysiologic significance. The curve, or the series of survival curves on the left side, really are just one example of many I could have shown that show the broader the QRS, the worse the mortality. If you have a QRS duration of 220 milliseconds, you have 5 times the mortality rate than compared to somebody with a narrow QRS. And this is a relationship that's been borne out again and again. And so by resynchronizing the ventricle, what we actually do is put a wire in the right ventricle, or a lead in the right ventricle, a lead in the right atrium, and a lead through the coronary sinus that runs in the AV groove, and deliver the lead epicardially to the lateral wall, the free wall of the left ventricle. And we can time the atria and the ventricles, the left and right ventricular activation, to try and improve cardiac output and resynchronization therapy. It sounds like a good idea, and you may wonder, does it work? Well, in the lab, when you do hemodynamic studies, you can affect a significant improvement in myocardial stroke work. So the curves on the top just show what happens when you pace a heart from the right ventricular apex or the septum, you don't see any change in right ventricular stroke work. When you pace from the left ventricle, the free wall of the left ventricle, you can see an increase in stroke work. Patients don't care about stroke work, they care about outcomes, and we'll lead into that. This is an ECG that exemplifies on the top someone before CRT with a left bundle branch block. After cardiac resynchronization therapy, you see that the QRS is a little bit narrower, the axis is shifted to a sort of a northwest axis, and you've changed the vector across the precordial leads, and this tells us this patient has effective resynchronization therapy. And here's the survival data. A couple of big trials from the last decade have shown that if you give CRT to somebody, whether or not they have a defibrillator in place, you can see an improvement in survival. The companion trial that some of you may be familiar with really looked at over 1,500 patients with very symptomatic heart failure, class 3, class 4 heart failure. It's an invasive therapy. Should it be reserved for people who are the sickest? And these are patients with a broad QRS, patients with a low ejection fraction, and resynchronization pacing with or without a defibrillator had a clear survival advantage in the order of 25 to 35% over pharmacologic therapy alone. This is another study, the Scud Hef Trial. Again, not to get bogged down in the details, but this is a resynchronization pacing trial that followed patients for longer, and patients that were very sick with advanced heart failure who had CRT lived longer by about 36% or 34% over the duration of the trial. So this is, compared to medical therapy, a very effective life-saving intervention. And that's led to the 2006 and updated in 2009 Canadian Cardiovascular Society guidelines that suggest if you have very severe heart failure and you're otherwise on optimal medical therapy and you're in sinus rhythm and you have a bad ventricle and you have conduction delay on the ECG, you should be considered for CRT. And we may be making further strides in broadening our population that's eligible for this. I've shown this graph before, but one of the questions that's raised is whether or not we can alter the natural history of resynchronization therapy. If we can prevent people from becoming symptomatic and prevent them from coming back into hospital, maybe we should intervene early, take the upfront risk of the procedure itself for the long-term trade-off of a reduction in morbidity and mortality. That's what the MADIT CRT, now a couple years old, showed, and this took a very asymptomatic or minimally symptomatic patient population. These were patients with class 1 or class 2 heart failure, and on medical therapy, patients, they all had defibrillators. Some of them had CRT on top of a defibrillator, and this showed a 40% reduction in heart failure events. That's fine, and then pathophysiologically, the really interesting thing is these patients with resynchronization therapy had a much improved ejection fraction over the course of the study and smaller ventricles. So there was an effective physiologic effect that translated into improved heart failure events. And then Dr. Ha alluded to the RAFT study. This is a Canadian-led study that looked at patients who were predominantly minimally symptomatic with their heart failure. And this is the first study, and it is now a classic in its own time. It looked at 1,800 patients. It showed a survival advantage with resynchronization therapy over and above a defibrillator. So even though we can prevent sudden death in an at-risk population with a defibrillator, if you add cardiac resynchronization therapy, you can also see an additional improvement in mortality, and that's in the current era, 2010, on optimal medical therapy, conventional current therapy, which is really staggering. And this is a 25% reduction in mortality. And that's led to the 2011 update and guidelines that suggests that we, as in the Canadian Cardiovascular Society, recommends the use of CRT for heart failure patients with minimally symptomatic heart failure, low ejection fraction, and ideally a very broad QRS. Practically, patients that do the best with this therapy have a very broad QRS, and over 150 milliseconds typically. So that leads to the natural question, I suppose, is should we just put CRT in for everyone? And I would suggest that maybe not yet. We still know that despite everything, about a third of our patients don't realize a real benefit from this. Maybe they don't feel better, they're not prevented from being hospitalized, and we're not very good yet at identifying who those patients are. We don't know if there are patients with a narrower QRS on the ECG, that have mechanical dyssynchrony, whether they would benefit. Patients with a right bundle branch block, I've talked a lot about the left bundle branch block, but it might matter. And what about patients that are very sick in the advanced stages of their disease? Is there a role for palliative CRT? Will it make people better, or is it just more invasive therapy that won't alter the natural history of the disease? And then one of the key questions that we're trying to get at in our clinic work is whether we should optimize patients, whether there's heart failure therapies we can add, whether we can improve the pacemaker timing itself to improve outcomes. I think in the real world, we're all cognizant of the risks of the therapy. There's Canadian data and US data on the left and right side of the screen in sequence. And the message here is that if you add cardiac resynchronization therapy over and above a pacemaker or a defibrillator, just that extra time, it typically takes 2 to 4 hours to do one of these procedures, and the extra invasiveness of the procedure, you can almost double the morbidity rate, and that's infection, lead damage, lead dislodgement, et cetera. And that's important when you think of what the average heart failure patient looks like. In the real world, it's a 75-year-old female with atrial fibrillation, diabetes, COPD, and chronic kidney disease. And you have to really think about whether your patient in front of you in the real world is going to benefit the same way a clinical trial patient would from an expensive and invasive therapy. I think with imaging advances, we've heard a lot about imaging at the symposium, we may be able to direct the operative procedure a little more effectively, putting the wires away from areas of scar that won't effectively pace the ventricles. Advances in lead technology should give us more options to resynchronize the ventricles. And here's one of the innovations that we're taking on at the PMCC. We have a collaborative clinic between the arrhythmia specialist, the heart failure specialist, our imaging specialists. We try and put the whole story together in a patient-centered approach and really figure out how we can best optimize the patient in front of us who may not be doing well. It's great when they do well, but we're also interested in the patients that are not doing well because there may be incremental gains that we can afford them. And this is essentially my second last slide. This is the RAFT study again with its spectacular 25% reduction in mortality with the $25,000 pacemaker defibrillator device. This is the emphasis heart failure data, the same 25% mortality reduction over a shorter period of follow-up, and this costs about $1 to $2 a day for either spironolactone or eplerenone. The message is don't forget the importance of medical therapy. It's just as powerful, and these device therapies should be considered over and above optimal medical therapy. So in summary, device therapy and AICD or CRT, these devices improve outcomes in patients with chronic heart failure. There's a reduction in sudden death. There's a reduction in heart failure death and hospitalization. Patient selection is key. Consider referral to a device specialist for persistent severe systolic dysfunction despite optimal medical therapy. And the target population is evolving, and every couple of years we may be able to come back and update the audience with where are we at now, because it's a bit of a moving target, and we're refining our patient selection, hopefully to translate into improved rate of patient response. So early intervention may be appropriate, and I'll end there. Thanks very much.